for the invitation, and for the chance to talk with you today about convalescent plasma therapy as a treatment option for COVID-19. To start off, I have no disclosures, and these are the objectives of this morning's talk. I would like to walk you over the current treatment landscape for COVID-19, and I would like to expound on the mechanism of action of convalescent plasma therapy. Later, we will call it CPT for short, and the potential risks associated with its use. I would also present available evidence regarding its efficacy and safety, and finally present our institutional protocols regarding its use and our early experiences. As of June 16, 2020, there are a total of 26,781 confirmed cases of COVID-19 in the country. We are still getting around 300 to 400 new cases per day. Let me give a brief review of the pathophysiology and the various phases of COVID-19 disease progression. Stage 1 corresponds with the time of inoculation and early establishment of the disease, where most people have mild and non-specific symptoms. Remember that SARS-CoV-2 binds to its target using the ACE2 receptor, which is highly expressed in the lung, the ileum, the heart, and the kidney. SARS-CoV-2 then multiplies and establishes residence in the host, primarily within the respiratory system. So characteristic of the second phase of illness is viral multiplication and localized inflammation in the lung. And during this time, the patients develop viral pneumonia and possibly hypoxia. Unfortunately, a small proportion of patients, around 5 to 12%, will progress into the third and the most severe stage, highlighted by extensive systemic inflammation, where systemic organ involvement, ARDS, and hemodynamic instability usually manifests. The optimal treatment approach for COVID-19, unfortunately, is still not known. Treatment approaches are based on limited data and evolve rapidly as new clinical evidence emerge. This figure also shows the various treatment modalities being applied during the different phases of the disease. Take note that all of these are investigational at this point, as no single drug yet has been proven to be effective for COVID-19. Alongside convalescent plasma, we have remdesivir, chloroquine, and hydroxychloroquine. And I believe we had a report this morning from Reuters that the WHO Solidarity Trial have already stopped enrolling patients within this arm. And we have interleukin-6 inhibitors like tocilizumab, JAK inhibitors like ruxolitinib, and many others. So what is convalescent plasma? Convalescent plasma is plasma taken from a person who has recovered from an infection, in our case, COVID-19. This plasma contains neutralizing antibodies against COVID-19. This plasma is then transfused to another patient afflicted with COVID-19 as a form of passive antibody therapy. Passive immunization with convalescent plasma delivers short-term immunization to the recipient by providing COVID-19 specific antibodies. Convalescent plasma obtained through apheresis and whole blood donation contains neutralizing antibodies, anti-inflammatory cytokines, clotting factors, natural antibodies, defensins, pentraxins, and other undefined proteins. The main mechanism by which CPT helps in COVID-19 is through viral neutralization. In SARS-CoV and MERS, neutralizing antibodies bind to spike-1 receptor binding domain, S1N terminal domain, and S2, thus inhibiting their entry and inhibiting viral amplification. The FV region of immunoglobulins typically mediates viral neutralization. As mentioned earlier, there are also other protective antibodies in the convalescent plasma. These are non-neutralizing antibodies.
Excuse me, Doc.
Yes, sir.
We have some viewers who can't hear the audio. Can everyone hear the audio of Dr. Gawiran?
How about you, sir? Naririnig niyo naman po?
Yes, okay.
Okay po.
Okay po, naririnig po nila. Okay, let's proceed po.
Okay po. So, as I was mentioning, we also have non-neutralizing antibodies, which also bind to the virus but do not affect its capacity to replicate. These are thought to contribute to prophylaxis and/or recovery. Similar with intravenous immunoglobulin administration, CPT also provides immunomodulation by neutralization of cytokines, complement, and autoantibodies. These effects are mediated by the FAB region of your immunoglobulins, and CP infusion may actually modulate immune responses via the Fc gamma receptors as well. So in addition to all of those that I mentioned, the convalescent plasma may also enhance anti-inflammatory properties of your dendritic cells, your T cells, and your B cells. So given all the aforementioned mechanisms of action of CPT, convalescent plasma seems to be of benefit in the whole spectrum of COVID-19 disease. Although most experts will recommend to give it earlier during the disease process to affect more viral neutralization, which is its special property actually. So convalescent plasma therapy as a form of passive antibody therapy is actually not a new therapeutic modality. As early as the 1890s, Bering and Kitasato have started using passive antibody therapy for the treatment of diphtheria and tetanus, with Bering eventually receiving the Nobel Prize in 1901 for this work. Afterwards, passive antibody therapy was increasingly being used for other illnesses. However, it took a step back during the 1930s with the development of more effective antibiotics such as sulfonamides and penicillin. In 2003, CPT was again used for the SARS outbreak, and in 2009 for the H1N1 influenza virus pandemic. CPT was also used for the 2012 MERS-CoV epidemic and the Ebola outbreak from 2014 to 2016. So the earliest big data for the convalescent plasma therapy came actually from a meta-analysis by Luke and Associates in 2006, wherein they reviewed all reported cases of Spanish influenza. In their review, they found out that there is a lower crude case fatality rate of 16% for those who were given CPT versus 37% in those who didn't receive it. A prospective cohort study by Cheng and Associates in 2004 also showed a benefit from CPT, especially among those who, with SARS who deteriorated despite antibiotics, antivirals, and steroids. This study highlighted that early administration of convalescent plasma leads to more benefit, and this study also showed early safety data for CPT. Perhaps one of the most striking evidence of convalescent plasma therapy efficacy was a study done by Hong et al. In 2009 on 93 patients with severe H1N1 infection. Hong was able to show a mortality benefit for the use of convalescent plasma obtained by apheresis with neutralizing antibody titers of more than 1:160. Those who received convalescent plasma therapy were found 80% less likely to die from the severe H1N1. In contrast, a non-randomized study by Van Grinsven in 2016 on patients with Ebola virus infection failed to show a statistically significant difference in mortality rates among those who received about half a liter of convalescent plasma, although there is a slight trend to benefit. It must be noted, however, that there were no serious adverse events among those who received convalescent plasma, further highlighting the acceptable safety profile for convalescent plasma therapy. So transfusion of convalescent plasma is actually not much different from transfusion of regular plasma, and thus it carries almost the same risks of transfusion-related reactions. Although there are isolated reports wherein they were able to detect viral SARS-CoV-2 RNA in plasma samples from blood donors, further investigation on these donors failed to confirm the presence of variants in the blood. So there was actually no direct evidence that the virus could be transmitted through blood products. Furthermore, blood cells do not contain the ACE2 receptors on their surface. And as I've told you a while ago, the ACE2 is the binding target of the SARS-CoV-2. Furthermore, modeling studies have also shown that there's an extremely low chance, about 1 in 100 million, of collecting blood from a donor infected with the virus with the current donor eligibility criteria for convalescent plasma. Transfusion-related acute lung injury, or TRALI, is an important concern among patients with life-threatening COVID-19 receiving plasma therapy, as it may be difficult to ascertain whether hypoxemia or any respiratory status worsening is from the convalescent plasma transfusion or from the progression of COVID-19 disease in itself. Nonetheless, when we follow the strict definitions for TRALI, that will be really helpful in diagnosing this possible risk from convalescent plasma. It must be also emphasized that we are selecting donors with no prior blood transfusions and females with no prior pregnancies. And because of this is expected to mitigate the risk of TRALI significantly. So it goes down to 0.0008% of transfusions, as much as like 1,000 decrease in the risk of having TRALI. And again, adherence to standard blood donation, processing, handling, and transfusion protocols are expected to mitigate most of the transfusion-related reactions associated with convalescent plasma therapy. One important theoretical convalescent plasma therapy risk is what we call the phenomenon of antibody-mediated enhancement of infection, or ADE. So ADE is thought to occur when we have non-neutralizing antibodies or when we have suboptimal concentrations of neutralizing antibodies, which will then bind the virus and opsonize it. And then after it, it will become internalized by Fc receptor expressing cells. So within the cells, the bound virus and the immune complex will disrupt the normal antiviral immune response. And this will result in persistence of the virus. However, remember that SARS-CoV-2 infects cells with by binding to the ACE2 receptors. As of yet, these receptors have not yet been described in your myeloid-derived cells. Thus, the potential of SARS-CoV-2 causing ADE is actually less likely. However, nonetheless, caution and vigilance are very important in monitoring for the evidence of enhanced infection among patients with COVID-19. So ADE remains to be a theoretical concern at present. Another theoretical concern with CPT is possible attenuation of immune responses, which might leave the CPT recipients more vulnerable to subsequent reinfection. However, this concern seems modest compared to the possibility of actually averting disease worsening into life-threatening forms. So if this theoretical concern is actually proven to be real, which we don't have any evidence right now that is actually a real concern, recipients could be prioritized for vaccination against COVID-19 when this becomes available already. So given the historical benefits and acceptable safety profile in other several viral infections, the benefits of convalescent plasma therapy, they actually outweigh the risks. So given this paved the way for the resurgence of convalescent plasma therapy as a treatment option for COVID-19. So as early as March 27, Shen has published the first report of convalescent plasma therapy used now for COVID-19. So they presented a case series of 5 patients with COVID-19 ARDS. So these are very critically ill patients who have received convalescent plasma therapy on top of antivirals, other supportive medications, and even steroids. And they received convalescent plasma between days 10 to 22 of illness. Fortunately, there were no transfusion-related reactions, no adverse events were noted, and clinical improvement was actually seen within 12 days for all the patients. And furthermore, viral clearance was detected as well within 12 days. And 3 of the 5 critically ill patients were eventually discharged, and the 2 were in a stable condition when they did the reporting. So there was a patient who was on mechanical ventilation. They were able to pull the patient out. And there was even one patient on extracorporeal membrane oxygenation, or ECMO, that they were able to save from the procedure. This was followed by DOH publishing a cohort study with matched historic controls on patients with severe COVID-19 who are already on maximal supportive care with antivirals. So these patients received 200 ml dose of convalescent plasma with titers of more than 1:640. So as you can see, they have a lower dose because the titers for their products are very much higher than the usual ones. So the usual cutoff that we use is 1:160. So that corresponds to a dose of around 400 to 500 ml. Now, if you have higher neutralizing antibody titers than 1:160, you can actually give a lower dose for these patients. So these patients who received convalescent plasma therapy actually had clinical, laboratory, and radiologic improvement, and 3 were discharged. So when we compare it to the control group, where there are actually 3 who died, we will see that convalescent plasma therapy used in severe COVID-19 is well tolerated and is actually associated with improvement in clinical outcomes. Zhang also published a case series of 4 critically ill COVID-19 patients who received 200 to 2,400 ml. So they weren't able to explain the rationale for their doses, and they also did not mention the levels of their neutralizing antibody titers. But it's surprising that some of them were given actually more than 2 liters of convalescent plasma, because it's so hard to get a lot of these blood products. So they were given plasma on top of all their supportive therapies like antivirals and interferon. So all these patients showed clinical improvement, and the virus was actually cleared between 3 to 22 days from convalescent plasma therapy. And of the 4, 3 were eventually discharged. And important to note that there are also no serious adverse events noted. So these 3 studies from China have placed convalescent plasma therapy in the limelight and sparked interest regarding its use as an investigational drug in various countries. However, these papers were actually criticized because of their study design. They were just case series and not randomized controlled studies, and there was absence of control groups in some of them. In general, these studies do not necessarily prove efficacy, effectivity, or safety, as the contributions of the various supportive care and other investigational therapies that the patients are also receiving cannot be reliably assessed. So during this time, they said that there is still insufficient evidence to support the routine use of convalescent plasma therapy for critically ill patients with COVID-19. Around this time, in the United States, under the leadership of Professor Arturo Casadeval, an immunologist at Johns Hopkins University and a staunch believer of antibody therapies, established the National COVID-19 Convalescent Plasma Project. You can access these online at ccpp19.org. So this group has been helpful in crafting the convalescent plasma therapy protocols in other institutions worldwide, ours included. In April 3, the US FDA has released special pathways for the use of convalescent plasma therapy, an investigational product, and established the patient eligibility criteria for its use. So the US FDA special IND access was limited to adult patients with severe or immediately life-threatening disease. So it's defined as follows: severe disease when you have any one or more of the following: dyspnea, RR of more than or equal to 30, O2 stats of less than 93%, PFR of less than 300, or having lung infiltrates of more than 50%, within 24 to 48 hours. And life-threatening disease is defined as patients having respiratory failure, needing mechanical intubation, septic shock, and or those who have multiple organ dysfunction. And central to this is the need for informed consent, because this being an investigational drug at present. In April 6, the PSMID has already included CPT in the United COVID-19 algorithm for hospital care, which it has crafted alongside other key organizations. So as you can see, convalescent plasma therapy was included as an option for those with critical disease or those with acute respiratory distress syndrome. So the renewed interest for CPT has sparked a lot of clinical trials designed to assess its efficacy and safety for COVID-19. Currently, it is being investigated for use among high-risk children, as post-exposure prophylaxis in adults, particularly in healthcare workers, and among COVID-19 patients within the spectrum of the severity, so from the mild disease to the more severe disease, and even outpatients with symptomatic illness. And as of June 16, 2020, there are at least 101 registered clinical trials worldwide investigating the use of plasma-based therapies for COVID-19. So in the past weeks, the results of the larger studies regarding plasma therapy have been coming out. The more important of which are this one, Joyner et al. Recently released their study, still a preprint, and it was not yet peer-reviewed. So they were describing the early safety indicators for COVID-19 based on the data of patients who received plasma therapy under the US FDA Expanded Access Program. So they analyzed 5,000 patients with severe or life-threatening disease, and even those who are judged of having high risk of progressing into severe or life-threatening disease. And out of the 5,000 patients who received the plasma therapy, only 36 serious adverse events were noted within 4 hours of transfusion of the plasma. There were 15 deaths, but only 4 were judged to be possibly or probably related to CPT, and none actually was described as definitely related to convalescent plasma therapy. There were 7 cases of TACO and 11 cases of CHALI, which are well within the usual TACO rates of 1% and the usual TRALI rates of 0.1% to 5.8% among ICU patients, which are seen in regular blood transfusion. And there were 3 cases of severe allergic reactions. The overall 7-day mortality rate was 14.9%, which is actually not alarming given that the case fatality rate for COVID-19 among hospitalized patients ranges in between 15 to 20%, and even as high as 57% among those admitted to the ICU. So this study by Joyner proves that convalescent plasma is safe in hospitalized patients with COVID-19, and it really made us more confident in giving convalescent plasma therapy for our patients. Liu et al. Also recently uploaded a preprint. Also, when we say preprint, this is not yet peer-reviewed. This is a matched cohort study wherein there are 39 adult patients with severe or life-threatening disease. They received convalescent plasma therapy, 2 doses of 250 ml, so about 500 ml, with antibody titers of more than or equal to 1:320. So this is a bit high. And they found out that there were no significant difference in terms of respiratory disease after 2 weeks. However, this study showed that convalescent plasma therapy was significantly associated with improved survival among those with non-intubated patients when we compare them to those who are already intubated. But there are some factors and confounders in the study which makes us less confident in their results. Actually, the convalescent plasma therapy group had higher proportion of patients receiving anticoagulation, and we know that anticoagulation actually affects the natural course of the disease, as they were saying that that COVID-19 is actually a prothrombotic condition. So, however, there is no evidence to say that the effect of plasma depended on the duration of symptoms of the patient. And finally, in June 3, the results of the first randomized controlled trial on convalescent plasma therapy was published by Lee and his colleagues in JAMA. So this RCT was an open-label, multi-centered study involving 7 centers in Wuhan. Unfortunately, it was terminated earlier than they wanted to. They weren't able to achieve their total participant target of 200 because they were already able to enroll more patients. As starting March 24, there were already no new cases in Wuhan. So they had to stop because they don't have any new patients that might require CPT. So the intervention group were given convalescent plasma therapy at 4 to 13 mils per kilogram. With this time, they didn't use the neutralizing antibody titers as their basis, but they used an ELISA IgG titer of at least 1:640. But they said that this has good correlation with neutralizing antibody titers of more than 1:160. So the primary outcome was clinical improvement within 28 days. So 52 were randomized into the convalescent plasma therapy group, and then there were 51 who were given standard of care as control. Though again, interpretation may be hard because the trial was terminated early, but when we see their results, CPT use actually did not result in statistical improvement, a significant improvement within that time to clinical improvement within 28 days when taken as a whole. But when they divided the analysis by severity, they found out that those who have severe disease had better outcomes compared to those with life-threatening disease. So this is very important. Secondary endpoints like 28-day mortality appeared to signal a more favorable outcome among the patients who were receiving convalescent plasma therapy, but this was not actually statistically significant. It was just a trend towards a more favorable outcome. So this study of FLEE is important because it emphasizes that antibody therapies work best when administered earlier in the course of the disease. So the lack of efficacy of convalescent plasma therapy for those patients who are already on mechanical ventilation and those with multi-organ failure suggests that the pathologic process within these patients might likely be irreversible at that point in time, and the convalescent plasma therapy won't be of much use anymore. So also, the high negative conversion rate seen within the viral loads of those who receive plasma therapy emphasizes the viral neutralization effects of convalescent plasma therapy. The study by Lee also underscores the safety of use of CPT with only 2 adverse events among the 52 who received the intervention. And one of them was actually just a minor skin rashes, and the other was possible severe transfusion-associated dyspnea. So this is the diagnosis that we give when we aren't sure if this is just TRALI or whether this is TRALI or a progression of the disease. So by definition, it didn't fall within the TRALI criteria. So it's just labeled as transfusion-associated dyspnea. So the results of the study of Lee provides optimism for the future of antibody therapy in the treatment of COVID-19. Now let me use the remaining time to present our local experiences with convalescent plasma therapy. So our team at the UP-PGH has been working with regional experts like ISBT and WHO in crafting our CPT compassionate use protocol for COVID-19, which you can download from the isbtweb.org. Just check on the Western Pacific region. Patient eligibility for compassionate use of CPT in UP-PGH was based largely on the US FDA criteria, which is also being used by most centers. So we are going to give compassionate convalescent plasma therapy under compassionate use for adult patients with laboratory confirmed COVID-19. So they should be having results of RT-PCR saying that they're positive, and they should be of severe or immediately life-threatening disease severity, which I have mentioned a while ago. So any one of these will already qualify the patient to receive compassionate use. And we wanted to limit the giving of convalescent plasma therapy within 3 to 21 days because we wanted to exploit the viral neutralization effects. And as we have seen from the previous study, the earlier that you give the plasma therapy, the better the outcomes will be. And it's important that these patients are not diagnosed with IgA deficiency because those patients with IgA deficiency are actually at high risk of having anaphylaxis from blood transfusions in general. And most important, they must be able to provide informed consent as this is just an investigational drug at present. So in the event that the patient cannot consent, we can have a legally authorized representative to sign the consent for them. And together with our colleagues in pediatrics, we have also provided a special access for pediatric patients, which is also based on some of the recommendations of the National Convalescent Plasma Project for COVID-19 by Professor Casadeval. So the indications are very much similar to that of adults, but with special focus on high-risk patients. In our case, children who have baseline immunosuppression, meaning children with cancer or undergoing chemotherapy, and those with primary immunodeficiency syndromes, except of course the IgA deficiency, which will be very problematic if we give them blood transfusions. So as opposed to the adults, the pediatric patients have more limited available medications, unlike the adults which have tocilizumab and other treatment modalities. So the transfusion protocol starts off with starts off with identifying a type-specific unit. So you can use this table to check which plasma blood types you can use for all your patients. And this type-specific unit will be thawed at 37 degrees Celsius. So we transfuse a total of 2 aliquots of plasma, so 250 ml times 2 per patient. And each aliquot will be transfused over 2 to 3 hours. I will explain later why we chose to give it at a longer duration compared to the others. With usual transfusion. And there's an interval of 2 hours between each aliquot. And for pediatric patients, we give 10 to 15 mils per kilogram over 2 to 3 hours. So the dose that we used, the 500 ml, was based on a target protective antibody titer of about 1:25 for a regular 70 kilogram recipient with 0 baseline antibody titers. And data from a previous study by Duan, which I presented a while ago, citing that actually 97.5% of donors for convalescent plasma therapy that were chosen very similarly as ours actually have high neutralizing antibody titers of at least 1:160. Unfortunately, we don't have special tests in the country like the plaque neutralization test, wherein we can easily identify the neutralizing antibody titers. So as of yet, we are using surrogates such as the lateral flow immunoassays for the presence of IgG to say that our plasma products actually contains enough antibodies. So remember that patients with severe and life-threatening COVID-19 disease actually are very fluid sensitive. If you give them too much fluid, they're at higher risk of having more lung injury. So we want to give them the fluid at a slower rate than usual. So for those who are at even higher risk for volume overload, you may consider increasing the interval between the 2 aliquots and giving a dose of intravenous diuretics to decrease the volume load. And you might also consider decreasing or having the total dose to just 1 aliquot, but this should be discussed with the clinical care team, as when you decrease the total dose, you are also effectively decreasing the neutralizing antibody titers. And vital signs and oxygen saturation should be closely monitored prior to infusion, at 10 to 20 minutes after start of infusion, and at completion of infusion, and finally, within an hour after its completion. Pre-treatment with paracetamol and diphenhydramine may be given as per clinical care team's decision, especially for those patients who already had prior transfusions and they had reactions. So you may consider giving paracetamol or diphenhydramine, or both even. So transfusion should be slowed or stopped if an adverse event develops, and it should definitely be halted and not restarted if patients develop anaphylaxis or severe allergic reactions, and you have to report to the blood bank when you have this blood transfusion reactions. And convalescent plasma therapy recipients should be closely monitored using your institutional standard pathways to assess its effectiveness. And the monitoring may include, but are not limited into the following: the overall clinical status of the patient and the vital signs, especially the oxygen saturations, inflammatory markers like your high sensitivity CRP, LDH, ferritin, and interleukin-6. This is available. Chest radiographs or CT scans, and ABGs to check for the PaO2 or over FiO2 ratio or PFR. So based on our early experience, CPT seems to be generally well tolerated. And review of clinical and laboratory data show that CPT appears to be helpful in improving inflammation, as evidenced by decreasing trends of inflammatory markers like LDH, ferritin, and CRP, and improving respiratory status, as evidenced by increasing PFR trends and improvement in chest imaging abnormalities among its recipients. And very much parallel to the findings of the early published reports, CPT appears to be more effective for those with severe disease compared to those with life-threatening disease. And it must be emphasized that CPT is only one of the many investigational therapies being offered in most institutions. But there is generally no problem with giving it alongside other investigational agents, especially tocilizumab, which is often being given for patients with severe or life-threatening disease. So they fall within the same category of patients who might benefit from it. And in terms of hemodialysis or hemoperfusion, there are no timing concerns as there is no theoretical risk that these modalities, hemoperfusion and hemodialysis, will absorb or remove the antibodies. So you can just give them alongside these modalities. But it must be emphasized that the performance of CPT should always be aligned with the Philippine FDA and DOH standards with regular reporting of outcomes. We do weekly updates on our CPT or CPS and we submit it online through email. And we also report our serious adverse events to the FDA using the DigiFlow drug monitoring management system. So the management of COVID-19 is rapidly evolving, but moving forwards, the convalescent plasma therapy protocol should be actively updated as new clinical evidence emerge. So we should always be on the lookout for the results of the ongoing studies and adjust accordingly. So local clinical trials on CPT are also underway, which will eventually provide more answers to our other questions. If CPT is indeed proven to be effective for convalescent for COVID-19, this will pave the way to transition towards hyperimmune globulin products, but this will definitely need a larger donor pool and maybe eventually lead to monoclonal therapies like palivizumab that we have right now for respiratory syncytial virus. So in summary, convalescent plasma therapy, though still investigational at this point, is a safe treatment strategy which may be used in the treatment of COVID-19 as a bridge while we wait for definitive therapies and the development of a viable vaccine. And it works by viral neutralization and immunomodulation. And CPT appears to be more effective when given earlier during the course of disease, before the patients go into frank respiratory failure or before they develop septic shock. And we anticipate the results of clinical trials to further elucidate the safety and efficacy of CPT and to actually identify the best subset of patients which will benefit most from it. With these, I end my presentation. Thank you very much for your time and attention. And for other inquiries, you're free to email me using this email address. Thank you very much.
Okay, thank you, Dr. Gawiran, for the informative discussion regarding convalescent plasma. I hope we all internalized all about the mechanism of action of convalescent plasma, the potential risks, and also thank you, sir, for sharing the review of evidence on its safety and efficacy and also the treatment protocol. I hope our viewers were able to gain knowledge with regards to the treatment we call convalescent plasma, especially in the time of COVID-19. Thank you, sir. To the viewers, kindly reserve all your questions. We still have one more topic. May I just confirm the presence of our next speaker, Dr. Bobong Tagayuna. Hi, Doc. Are you here? Hello, Doc. Okay. Dr. Bobong, are you here?
I cannot see.
Okay. Our next speaker is here. So our next topic is about the initiatives of the Department of Health, PBC, in response to emerging and re-emerging infections. Joining us today is Dr. Pedrito Tagayuna. Dr. Tagayuna, also known as Doc Bobong, is a pathologist. He took up Doctor of Medicine at Far Eastern University, Dr. Nicanor Reyes Medical Foundation, a diplomate in clinical pathology, a fellow member in clinical pathology of the Philippine Society of Pathologists, and is currently the officer in charge, head of the Philippine Blood Center. He is also the head of the Information Management Unit under the National Voluntary Blood Services Program, a medical consultant at PGH, the Consultant Director Blood Bank and Transfusion Services at the Medical City. He is the chairman of the Laboratory Department of Fidelmundo Medical Center. He is the Blood Bank Head of Fidelmundo Medical Center, Pasig City General Hospital, PNP General Hospital, and is an associate professor at the FAU NRMF Institute of Medicine. Dr. George C. Peralta Memorial Lecture Awardee, Dr. Tagayuna is also a member of the International Society of Blood Transfusion, American Association of Blood Banks, and American Society for Apheresis, among others. So again, we are very pleased to have with us Dr. Tagayuna. Hi, Doc. May I ask Dr. Tagayuna to take over the discussion, please? Hello?
Hello?
Okay. Okay, Doc.
Can you hear me?
Yes, Doc, we can hear you.
So good morning, everyone. Um, I'll be talking about the doctor. My apologies, I was supposed to speak first before the room because I'll be talking about the convalescent plasma collection or the DOH-13 blood center initiative in response to emerging and emerging infections. This has been mentioned, I think, by the earlier speaker. Coronavirus is now a pandemic. This slide shows you the technology of events. So this was from yesterday's presser. There are now 27,000 cases in our country, and there are 6,820 recoveries. So I'd like you to remember the number 6,820 because these recovered patients will be our source of comparison. Okay, just to recall, this is a convalescent plasma treatment. It's still investigational, and the mechanism is just using the convalescent plasma, collecting convalescent plasma from a patient that recovered from a disease such as COVID-19 to a patient having the disease. The dose will vary depending on the protocol. There were clinical trials protocols that were presented by the doctor. The adverse event would be similar to any transfusion, any blood products that you transfuse. Timing of administration and also different protocols.
Hello po. Excuse me, Doc.
Yes.
Hello. Doc, we just have a concern. Choppy daw po. Okay. That's... Hello?
Yes, hello.
Ayan, that's clearer, Doc. Okay, proceed po.
Okay. Just trying to show you the normal, the immune response that the person has. This part of the one here is the IgM. Sorry, the viral B is the IgM, and the headline is the IgG. So we are going to collect plasma in the convalescent state, wherein we are supposed to see the elevation of the IgG and already the decline of the viral load, the IgM. So at this point, we test for IgM and later we will see. Just remember this part. Convalescent. Okay. So this is we when we collect plasma from recovered patients, we can do it by the conventional whole blood donation or also, and then another one is plasma donation. This is very ideal method of collection because you can collect more frequently. So this is the donor that has recovered from the disease, and you see those representation of the virus. And we draw blood, and the apheresis machine will separate the blood into plasma and red cells. So the plasma will be transfused to the in the US, the pathway of using convalescent plasma, there are three pathways: clinical research, compassionate use, and expanded use. In the US, convalescent blood products in general is being regulated by the FDA. So these are the pathways that were written in the guidelines of the US FDA. In the Philippines, we have a different setup because blood collection here in our country is being regulated by the HFSRB through the National Voluntary Blood Service Program. This is the blood collection. So this will include uh, convalescent plasma because this is a blood product or blood derived. While the use of the blood product is being regulated by FDA. What we are going to do, so what we are going to do in the Philippine Center, what we are doing in the Philippine Center is the expanded use. When we say expanded use, we just keep on collecting convalescent plasma and then we distribute them to the hospitals or to the hospitals for compassionate use, or they can also in the setup of Philippine Blood Center, those hospitals or institutions that would like to conduct clinical research, uh, Philippine Blood Center can collect them, and then collect the convalescent plasma for them. So who can donate? This is most of the collection protocol. Most of those the collection protocol that was adopted by the Philippine Blood Center actually came from the protocol of the Philippine General Hospital. So we group the recovered patients into three. So our study of preference first those that those that has a testing for RT-PCR, initially positive, and those with recovered RT-PCR negative test. And we wait for 14 days absence of symptoms. We will not do IgG, IgM testing. Second is for those who are positive to COVID-19 RT-PCR, but on recovery, no RT-PCR is done or is not have 28 days. We count 28 days from the absence. And we do not test for IgG. Third is those that do not have RT-PCR initially in or a repeat upon recovery, but had the symptoms, we wait for 28 days, but we test for IgG. But in practice, we actually test IgM and IgM before the donation because we already have it in the PIA machine. So what are the other criteria? So the conventional criteria for donor acceptance for conventional donation will apply to those donating convalescent plasma. Preferably no history of transfusion in those transfusion, transplantation, stem cell transplant. And females that have been pregnant. This has been mentioned by me because of the risk of preventive family, those patients receiving plasma from this type of donors. What are the laboratory tests? Laboratory tests, I mean, when I say laboratory tests, it's a test done to the patient, right, to the donor. The CBC, and what is important in CBC will be the hematocrit and the platelet count will have an effect on the plasma to be harvested, the volume of plasma to be harvested. That is very important. Because even if we separate the whole blood into the plasma and the red cells, in the backfill part, some of the platelets actually so they're separated into separate blood during the procedure. So we need the platelet count, and of course the hematocrit we are taking out. We are taking out plasma, which is important in maintaining the blood volume. We also test SARS-CoV-2 and we will not allow or we will not collect plasma only those without. How about those without IV? We also do not collect. Are those and then we also do HLA and HLA antibody screening for those donors. What the risk of developing once I mentioned pregnancy, is there pregnancy for female donors and the other. Collection, we can do whole blood collection and harvest the plasma using the refrigerated centrifuge. We do this on donors, on first-time donors. This is actually practice, but we need to see even those donors, even donors who are first-time donors, I believe the first time we already do convalescent, I mean plasma production, because based on our experience, only about 20% will actually get accepted within blood among those with we already we can leave the donor and being it's large enough to accommodate the needle for plasma because in performing plasmapheresis, the pressure during the draw is very important, and the kit is quite expensive. That's why we have to make sure that we will be able to successfully collect enough volume of plasma. The volume that we collect as much that the donor can tolerate. But we will prepare the components into the depending on the cost. If they need 200, routinely as we're looking at the protocol of PGH, routinely we collect or we divide the value to 1 to 50 units in the alcohol. We are able to harvest 400, then 250 goes to 1 bag, and then 150 where we can use them in the applicator, or we can pool them to be able to have a volume of 250. The volume is affected, as I mentioned earlier, by the height, weight, and the amount of the patient, and of course, if the platelet is below 150, this machine will allow the patient. We tested the donor earlier. Now, if we test the convalescent plasma. So we test for HIV, hepatitis B, hepatitis C, syphilis, and malaria. These are the mandated testing for all blood transfusions and physical infections. We also test for antibody. This is not the SARS-CoV antibody, but the rare blood group antibody. Antibody, we only do antibody screening. In our center, we also do nucleic acid testing and negative validation test for the first three PTS, HIV, hepatitis B, and hepatitis C. Okay, we're supposed to test the CPU, but we also give the option to if they want to be tested, the day prior. Day prior, we go to their test and then take blood sample to test for CPU. Now, you might be confused that we are testing the CPU. What we do to the blood purity that is we run the nucleic acid testing on the blood test to this is a negative validation test for HIV. So how do we process? We also do pathogen reduction treatment prior to freezing. The pathogen reduction is not actually required in many papers that I've read. PRT is not really required for convalescent. This is expensive setup. But for all blood products, for plasma products, we do so we do.
Hello, Doc Bobong.
Yes.
Excuse me po. Sorry for interrupting, but we have concerns regarding the audio signal pa rin po. I think signals breaking up po.
Okay. But
Can everybody hear clearly?
because I have a very good signal there.
Okay. Okay, sir. Proceed po, sir.
I'm running on. Okay, so we freeze the plasma. There are blood service facilities to actually transfuse the plasma rest. In the blood center, we freeze because we don't have patients in the blood. Okay. So according to WHO, the plasma can be stored in following. We store it at negative for the last 3 months. If we store it at negative 65, what we call the ultra low temperature, can last up to 7 years. By then, the convalescent plasma. So it's okay to store it at negative. Before, you always have to check for cracks and signs of deterioration. Once thawed, you throw the frozen plasma 37. Once thawed, you can store it at 3 to 6 degrees, and you have to transfuse that in 24 hours. Do not decrease the thawed plasma. Labeling, I use a cryo-resistant label so that because if you use label that are in a cryo-resistant label, and it should include the temperature of storage, the date the blood was collected, or the plasma was collected, expiration depending on the storage. So to remind you that if you store it at negative 65 and then move it to negative 20 change the expiration. You also have to include the information in the packing, the meaning or in the anticoagulant information, the name of the blood source, and the special instruction. Used only for COVID patients. Transport between blood service facility and transfusion facility should be met with consent. So you can exclusively just the transport box and isolate. In transporting, you have to use the dry ice in the blood center. From the blood bank to the bedside, those flow plasma has to be like transport box that is 2 to 10. Transfusion, this is already what we do in what the blood bank will do is just perform blood typing in the unit. That's this text specific. Transfusion specific. No need to process. And there will be the certain requirements for, as I said, FDA regulated transfusion and convalescent plasma. This is also. So the documentation, the usual documentation that let's say the specific donors, handbook, storage, regulation testing results, the donation, volume, the alcohol, testing that we're done. In the Philippine Blood Center, we were a non-hospital-based blood service facility. Long operation. We strictly adhere to voluntary non-immunity from the NIPD because we use convalescent plasma bars and we do not want up to the time where we have donors. We also do pathogen reduction and when Philippine Blood Center centralized risk program, it's actually intended to be a standby program, standby response to any emerging or hopefully combat. This is the part of the preparedness program. This is our section. If you can see
Doc
here.
Bobo.
Yes.
Sorry po, we cannot hear you po again. Hello?
Hello? Hello? Hello?
Okay.
Can you hear me?
Yes po, Doc, pero mahina po, Doc.
How about that? Hello?
Hello po.
Ayan, is it louder?
Still choppy po, Doc. I can't clearly hear po.
Hello?
Hello, Doc.
Yes, hello? About this one.
Okay, Doc. That's better po.
Okay.
Okay, Doc.
So this is our convalescent plasma donation section, and the other side here, you can see in the glass, that's the apheresis, our conventional apheresis there for platelet. and also our walk-in or in-house donation. We do the collection here. What is the reason why we separated the section? Because there are donors, our regular donors for whole blood donation, nepheries that would be worried about. They will be worried about, or they have the misconception that these recovered patients can still, recovered donors can still transmit the virus. And these are our digital posters. So if what will be needed to establish a convalescent plasma donation program? These requirements that I will be presenting you are from the Department Memorandum 2020-0216. Only blood centers or blood bank with additional functions can apply for certification to become a convalescent plasma collection center. You have to write a letter of intent to be submitted to both HFSRB or Health Facilities Service Regulatory Bureau and the National Voluntary Blood Services Program. These are the other requirements that are also listed in that department memorandum. A separate area, okay, and there are certain, we broken down into section area, donor counseling, donor health. If you want to operate on an 8-hour shift, you should have at least if you have one machine, you can handle 4 donors because and this is the reason why you have to perform the donation within 2 hours. Somewhere in the department memorandum, it's stated there that you should only collect plasma in 2 hours for each donor. The tube sealer, and these equipment should be separate from your blood bank or from the other areas where you do the collection. You should have a tube sealer in the convalescent plasma section. The others. Another will be the manual. You should include the manual in the manual operations of the blood service facility or the blood bank. Just showing you how will the certification process happen? Submit the letter of intent, prepare the requirements, and then NVBSP will schedule the inspection and the issuance of the certificate. Okay, let's make it. Thank you. Hello.
Okay. Thank you, Dr. Tagayuno, for your informative discussion regarding convalescent plasma collection. Also, it is indeed essential for not only Philippine Blood Center, but for all blood service facilities to be prepared whenever an emerging infection occurs. So I believe we can now proceed to the next part of our program, the question and answer. May I confirm the presence again of Dr. Gawiran? Are you still here, Doc?
Yes, Dr. Shua, still here. Thank you.
Okay, I think it's safe to say that due to time constraints, we will just allot a maximum of 15 minutes for the question and answer. So to the viewers, you may now ask your questions, but now we already have some questions from the viewers. The first question is from Sir Royland Baybayon. I think it's directed to Dr. Gawiran. Sir, it has been said in the presentation that the use of CPT is suggested and much more effective in the early course of the disease due to its viral neutralization properties. However, the patient eligibility to receive CPT is on cases with severe and life-threatening cases, which usually occurs on the latter stages of the disease. Pa-clarify naman po.
Um, Thank you very much for that very nice question. Actually, that's a very nice point po. But right now, because the actual access programs are only limited to the severe and life-threatening disease, when we say we try to give it earlier, that means they should be in the less severe stage, so yung nasa severe versus the life-threatening phase. That would be the perfect time to give it. So that's what we mean by earlier. And actually, we are planning a clinical trial on giving the convalescent plasma for all hospitalized patients, and our hope is that we can prevent them from going into the ICU or having ICU care. So that's another way of how we can give convalescent plasma therapy earlier than it is usually done. But right now, kasi the data that we have, we're only giving it for the severe and life-threatening disease as guided by the US FDA. So in terms of that, we would like to give it during the severe rather than during the life-threatening phase.
Okay. Sir Royland, I hope your question has been clarified. But Doc, with a follow-up question only in relation to that question. Could we give convalescent plasma therapy to those who are suffering uh, from a moderate case of COVID-19, or is this just reserved exclusively for severe or life-threatening infections?
So right now, when we talk about compassionate use of convalescent plasma, it's just limited for the severe and life-threatening disease. For the moderate cases, we're still coordinating with our specialists from infectious diseases, whether we can already identify those with moderate disease who are at high risk of evolving into severe disease. So we're looking at a model, a predictive model by which it can help us identify those who are at high risk of going to severe disease. And maybe when we have that model, so we can apply that for those with moderate disease so that we can give it earlier than usual.
Okay, Doc. Thank you po. Okay, another question. I think this is directed to Dr. Tagayuna. From Abigail Kyo, how can we ascertain a steady supply of convalescent plasma for use in treatment if and when CPT will be used as a treatment outside clinical trials? Doc Bobong? Hello, sir.
Hello?
Hello, Doc Bobong po.
Hello? Yes, hello.
Yes, can hear you po. Doc, the question is, how can we ascertain a steady supply of convalescent plasma for use in treatment if and when CPT will be used as a treatment outside clinical trials, sir?
Okay. So we have a donor recruitment program in the blood center, wherein we regularly send letters to those recovered patients. Question as to how we can sustain that one, that will be difficult because, as I have said, 20%, only 20% of recovered patients can actually donate or go, respond to the call of the convalescent plasma and will eventually qualify as a donor. This is why the blood center is doing the expanded collection, so that if there will be need for it, we can supply them back.
Okay. Okay, sir. Another question, Dr. Tagayuna. Do we have a laboratory capable of providing services in determining the antibody titer for COVID-19 recovered patients?
In TBC, we have that. And I think the technology is already available in the Philippines. And, well, I cannot name the suppliers, but there are now available platforms. We can also do that. I mean, if you have donors and you want us to do the the testing, we can do that.
Okay, Doc. Thank you, Dr. Tagayuna. To the viewers, do we still have 11 minutes for the question and answer? If you still have any questions, you can send it here. Okay, so
There is a question here. Are there facilities outside Metro Manila where one can donate convalescent plasma? I know Region 7 Blood Center can collect plasma. Davao Blood Center can collect. I mean, they're capable of doing collection. In Pampanga, JBL or JB Blood, so at least those three that I know.
okay, Doc. Thank you po. Okay, we still have some questions. Okay, so if we don't have any questions, I'm also curious, doctors. This is to Dr. Tagayuna po, Doc.
Mhm.
Can a COVID-19 patient who received convalescent plasma and then eventually fully recovered be able to donate his or her own plasma to other COVID-19 patients, Doc?
You mean a COVID? If okay,
Yeah.
that's a hard question. That will
Ah,
be the first time that I will talk. Okay. Theoretically, that donor can donate if he can comply with all the requirements, like RT-PCR test, he has IgG, then yeah, I think he can, and then that donor can.
okay, Doc. Thank you.
Hi, Dr. Chua. I'd like to add on to that question as well.
Yes, yes, Doc.
Yes. Actually, that's also a very interesting question that we had to discuss multiple times within the center. The main concerns regarding that, regarding allowing those who receive plasma as future donors would be first, since they had received convalescent plasma, which is just a passive immunization process, we rely on very transient effects. We're actually not very confident that they were able to mount the required immune system so that will make them good donors later on. That's a possible concern. But if we're able to demonstrate that they have enough antibody titers, then I don't think that shouldn't be a problem. And a second stumble block that I think we will face when we allow them to be donors is that since they were able to receive blood transfusions, they will definitely require to be tested for anti-HLA or HNA antibodies to prevent the risk of TRALI for those who will be receiving their blood. But overall, I think there really isn't like a strong reason to say no for these kind of donors, especially when we have problems with the donor pool already.
Okay. Okay, Doc. Thank you, Doc. Doctors, we have a question related to the available facilities in NCR. Currently, sir, what are the available facilities that we have for convalescent plasma collection?
I sorry. Sorry, was the question about? I think I already answered that. Where the facilities that collect convalescent plasma?
Yes, Doc. Yes, Doc.
Yeah, I named three. Davao Blood Center, Region 7 Blood Center, that's in Cebu City. In San Fernando, JB. In Metro Manila, I know St.
Okay.
Lung Center of the Philippines, those two that I'm sure forming. But there are, I think, few others to collect convalescent.
Okay, Doc. Okay, to the viewers, do you still have any questions? Okay. Anyway, doctors, I'm also curious. Since Dr. Gawiran already mentioned that the, the recipient of convalescent plasma, it's much better if it is given within 3 to 21 days. But on the other way around, what is the recommended in time that these COVID-19 survivors can donate blood? Is there a specific time frame wherein the COVID-19 survivors can donate their plasma?
You mean you mean like until at what point they can give? Because uh, it depends on remember the criteria that I presented. If they have both the RT-PCR positive and negative upon recovery, just 14 days from disappearance of the symptoms. If only an RT-PCR positive with no RT-PCR negative in recovery, that's 28 days. And if neither is present with RT-PCR, we can do the IgG, IgM test, but still you have to wait for 28 days. Maybe the question that you'd like to ask is how long can they on donation?
Yes, Doc.
Uh,
How long could they donate, Doc?
uh, until they have the enough level of antibodies. That's why we always test for the IgG before we proceed to the donation. Maybe also you can ask Dr. Gaviran if you can answer it.
Okay, Doc. Okay, thank you, Doc. Okay, do we still have questions? We have 3 minutes.
I think, sir, there was a question whether asymptomatic COVID positive patients can donate blood for convalescent plasma. I think, yeah, they can actually be good donors, but they will still have to be assessed in terms of the IgGs, especially because some of the patients are actually who had asymptomatic disease weren't able to mount the immune response that well. That means they don't have robust immunoglobulins in their system, but that will be checked during the process anyway. So I don't think they would be problems in if they want to donate.
Okay. Sir Kevin Lim, I hope your question has been clarified. Okay, another question, doctors. Can COVID survivors repeatedly donate their plasma? I think that has been...
Yes, every 14 days for if the donor donate plasmapheresis every 14 days, as long as there's enough antibodies. And for whole blood donation, the same as the blood donation. After 3 months, but we can actually allow after 8 weeks.
Okay, Doc. Thank you. Okay, I think I'll just accommodate last 2 questions. So if you still have questions, we can ask our speakers for today.
There's a question here. Can an institution do the blood bank with additional function request CP for their patient? Yes. If yes, where can they acquire the CP? From those who are certified to collect convalescent plasma, like Philippine General Hospital, and the others, that what will be the process? It's just like when you need blood from another blood bank, you coordinate with the blood bank.
Okay. Okay. Last question. Regarding the question of last, I think it's been asked earlier, Dr. Gawiran. Okay. Sir, if there are any questions, I have last questions. Doctors, if ever we don't have an HLA antibody screening in the facility, can people who had transfused or females who had pregnancy still donate their plasma, sir? If a facility doesn't have the antibody screening for HLA-HNA.
What you can do is you can still collect and then test it later once it's available in your institution, or you can send it to CDC. I mean the sample. I mean, you can send the sample to CDC work. But the disadvantage is you already use that kit.
Okay, Doc. Thank you, Dr. Bobong. Thank you also, Dr. Gawiran. So I think that ends our discussion and question and answer. So just to summarize our discussion today, blood products in general have three pathways: clinical research, compassionate use, and expanded use. Criteria for donating convalescent plasma was also presented. This includes also the testing of CP units. Requirements of setting up a convalescent plasma facility has also been mentioned. The treatment is still not known. Convalescent plasma treatment is still not known. Antibody therapy is not new. However, we have been using it and it showed promising results. Convalescent plasma, though considered experimental, still can be used as a treatment in the hopes of ameliorating this patient's condition. This is under, of course, compassionate use and is based on the promising results of using antibody therapy during previous epidemics or pandemics. Convalescent plasma can be given to severe or life-threatening COVID-19 infections. It also may be given with other investigational drugs. Potential risks of CPT includes the adverse effects of any transfusion procedures such as allergic reactions, TRALI, TACO, but also antibody-mediated disease enhancement, a possible attenuation of immune response, though there are not enough evidence, and transfusion-related risks. Okay, so I think that's it. We are very grateful for Dr. Tagayan and Dr. Gawiran for sharing your time and your knowledge with us, sir, especially with the treatment that is still unfamiliar to some, and that is convalescent plasma. Thank you, doctors.
Thank you very much, sir.
Okay. Before we end, may we listen to the keynote speech from Secretary Duque and closing remarks from Assistant Secretary of Health, Nestor Santiago. Okay, ma'am. Okay. Okay, are we ready for the video? Okay. I think the video is not playing, ma'am. Okay, I think we're having some technical difficulties. However, anyway, I would like to inform everyone that last June 15, 2020, we officially launched our convalescent plasma donation program at Philippine Blood Center. So if you are a COVID-19 survivor and you have inquiries regarding the procedure, don't hesitate to contact us at 8995-3846. That's 8995-3846, or you can reach us through email, apheresis.pbc@gmail.com. Yeah, is the video ready, ma'am? Okay, still not playing. On the other hand, if you are willing to donate the conventional whole blood donation, then feel free to visit us at the blood center anytime. We are open daily, 8 a.m. to 4 p.m. Contact 893. Is the video okay, ma'am? Okay, while waiting, we would like to acknowledge the people making this webinar series possible. Of course, the DOH-NVBSP, headed by Marites Estrella, and her whole team. In behalf of the Department of Health and Blood Center, we would like to thank everyone for supporting of in celebration of the 8th National Summit and World Blood Donor Day. We do hope that you continue to support our bloodlet activities, and we are encouraging everyone to start being a regular blood donor and continue to help save lives.